السلام عليكم ورحمة الله وبركاته جميعا and good afternoon or good evening everybody. ما أدري الصوت واضح للجميع ولا لا؟
نعم الصوت واضح.
ممتاز. فطبعا we will start our review of glaucoma cases by just having simple things and simple cases that we will discuss in each one of them. Some basic things like visual field and basic clinical approaches. Some other advanced things that we rarely see in the clinic, we will just leave it for your own review. Our aim today is just to polish the way in which you think, and you can approach most of the patients that you will get in the emergency room or as a referral in your general or glaucoma clinic. But I'd like to have your kind cooperation because we will have it like an interactive, discussion. So just to start with, all of you realize or know this map very well. That's what we call the Garwe-Heath map. And why it's important for us in glaucoma, because this map can actually inform you about the future hit in the patient's visual field. Just about visual field changes, because that's actually the main complaint of glaucoma patients. They have visual field defect, which will affect their visual potential later on, and can prevent them from functioning their daily life activity. So please keep this Garwe-Heath map in your mind. You need to memorize it very well. Most of the things in the Garwe-Heath map are inversed. So that's on your left hand, what you see is a circular band that mimics the optic nerve head. And the red color here zone represents the inferior temporal part of the optic nerve, in which if there is a significant thinning and loss of the neuroretinal rim, then you will have the inner inferior and the outer inferior part of your visual field. The most of the superior and inferior poles.
عفوا دكتور الصوت يقطع شوي.
السلام عليكم. واضح الصوت الآن؟
اي واضح.
طيب, sorry for the interruption in the internet connection. So we were talking about previously the Garwe-Heath map and the corresponding damage that we will get because of the optic nerve head damage and thinning from glaucoma. So we know now that we have certain optic nerve head phenotypes that are important for us. We need to know them very well and memorize them very well. We have focal, diffuse, and sclerotic optic nerve head phenotypes. The first important one for us is the focal optic nerve head phenotype, in which you will have unequal thinning of one of the poles, either the superior or inferior poles. But in far advanced cases, you will have a uniform thinning and loss of rim. Why focal is very important for us? Because it's the one that gives us the most rapidly progressive optic nerve head phenotype, followed by diffuse optic nerve head phenotype, and then the senile sclerotic, in which have a moth appearance and shallow cupping with pale appearance of the disc and adjacent peripapillary atrophy. Now, whenever you look at an optic nerve head image, you need to assess the disc very well and look which area of the disc is having the maximum thinning. so that you can think about the area of the next hit in the visual field. And the main aim, as we mentioned, is to look for the area of the hit in the visual field and to plan your management appropriately based on that. If you are having a rapidly progressive visual field defect and you are keeping the patient on anti-glaucoma medication, then you would rather change your modality of treatment, think about other options like surgical intervention. For example, this patient here is having an inferior thinning, which is a focal optic nerve head phenotype, giving us a corresponding superior scotoma. And you can see here that the scotoma is of significant density, and it's actually reaching or encroaching on fixation. Once you have a scotoma reaching or encroaching on fixation, you need to act fast, because once it's surround and involve completely fixation, then you will have something called split fixation, and you will have significant drop in the patient's visual acuity. I'd like to have a volunteer just to give us a reading or interpret this visual field. So do we have a volunteer?
I can take this case, Doctor.
Okay, go ahead.
طيب, this is a visual field of the right eye of a patient. I don't have the information of the patient. I only have the date of birth. The reliability indices, it seems reliable. Fixation loss is 0, false positive is 0, false negative is only 3%.
Okay, so what you mentioned, Khalid, here are very important information. You mentioned that this is the right eye. How would you know that this is the right eye? Because when you look at the blind spot, it's on your right hand. So if you can see the arrow here, the blind spot, so it's on your right hand, so that's the right visual field. You mentioned before the age, and the age is very important for us. Why is that? Because actually the software is comparing the patient's data to an aged matched normal population. So if you enter a wrong age, the machine will give us actually a false data. Either the patient is departing significantly from the age matched population, or the patient is actually matching an unrealistic age matched population. You mentioned the reliability indices, which is really excellent. Fixation loss is 0, which is less than 30%, which is less than 20%. We can accept 30% in patient who's having advanced visual field damage. False positive and negative are less than 20 to 30%, which is acceptable. Go ahead, please, Khalid.
We have the pupil diameter is 4.4 millimeter.
Excellent.
Yeah.
And that's important for us because it's important for follow-up of patients. If the patients keep having the same pupil diameter, then we know that there is no artifact causing or no pharmaceutical induced meiosis causing generalized depression of the visual field. Go ahead, please.
And then we can see the grayscale. We have a nasal stepping visual field defect.
Okay. Just before we go to the grayscale, I'd like to raise your attention for the test duration and for the fovea. The fovea should be always on. Please make sure that the fovea is always on, because the sharpest area of vision that we have is the fovea, right? So it doesn't make sense that the fovea is having the best, or having, a lower sensitivity, while the other periphery or other part of the retina, which is at the periphery, is having a better sensitivity. It tells you that there is something wrong in the test. So the fovea should be always on. Test duration is important. Patient who's having a prolonged test duration, it can tell us that actually the patient is getting fatigued. Go ahead, Khalid.
So going back to the grayscale, we have a nasal step and paracentral scotoma.
Excellent. And after that, where would you like to go? So you talked about, we have something called wander. W, what was done? So that's a 24-2, CETA standard test. And then we went for the accuracy, as you mentioned before. Or can you hear me, Khalid?
Yes, yes.
Yeah. So after that, you went for the reliability indices, and the test is reliable. Then you went to see if it's normal or not, and you mentioned that the patient is having nasal step and paracentral scotoma, right?
Yes.
So then you mentioned that the patient is having a glaucomatous defect, right? So the damage here that the patient is having, is it mild, moderate, or severe? Now you are looking on your left side to a focal optic nerve head damage, right?
Yes.
And you are looking at the visual field damage here. Is it mild, moderate, or severe?
We have the mean deviation, which is minus is 3.2.
0.8. Yes.
0.8. We have from 2 to 6, this is mild.
Excellent. And from 6 to 12 is moderate, and more than 12 is severe. So what you mentioned here is completely correct. So the patient is having mild optic nerve, or sorry, mild visual field damage. So after that, what would you like to do? So you will evaluate for compatible disease, and that's of course a localized superior visual field defect that comes with glaucoma. Frankly speaking, glaucoma because of focal optic nerve head damage. Then you will revise again and make sure that the data that you have given us are correct. Thank you very much, Khalid. Can I have another volunteer to finish the visual field section?
Can we have Dr. Saleh Al-Rashid?
Assalamu alaikum, Dr.
Hello, alaikum salam. So go ahead, Dr. Saleh.
So we'll start with the patient's information. And it's blacked out in this photo, but we know this is a left eye with the date of birth written on the upper right side. Then we can see that this is a 24-2, CT standard white on white. And
so now you are doing the W, what was done, right?
Yes, yes.
Okay, go ahead.
And then we see the reliability indices. We see that the fixation is central, fixation loss is 0 out of 17, and the false negative and false positive are reliable. You can see this test.
So what do you mean by false positive and false negative? What's the importance of false positive and false negative? What do they mean for us?
They mean for us that we can rely on this test one, and they mean for us what the patient did during the test itself.
Exactly. So yes. False positive is what exactly?
It's when the patient is trigger happy.
Exactly. So he is keep pressing the button for a stimulus which is not existing.
Yes, yes.
And what about false negative?
It's when you put a stimulus on the patient and you decrease it and you repeat it again and he's not responding to it.
So you are giving him a brighter stimulus.
Yes.
And the patient is not seeing it on the same site in which he saw before a dimmer stimulus. So when we talk about bright and dim stimulus, in visual field, it's the opposite. If you have higher number, it means that it's a dimmer stimulus because you are talking about decibels. If you are having lower numbers, then these are brighter stimuli.
Yes.
So 100% correct. Can you complete, please?
We can also comment on the pupil diameter for this patient and the age of the patient as for follow-ups and to see how the machine tested based on the demographics of the machine. And you can see that the fovea is on for this patient, and we can go ahead and proceed to see the grayscale of the patient.
Okay.
So what we can see here is visual field defect mainly in the peripheral area of the grayscale, and we can proceed down to see if it's a true deviation or not by seeing the total and the pattern deviation of the patient, meaning that was there a medial opacity for this patient or not.
Okay, so we have two scales here. We have the total deviation and the pattern deviation. The total deviation will measure the deviation of the patient from his age matched population. يعني كيف سوى المريض مقارنة بالمرضى اللي بمثل سنه. فهذا هو total deviation. إذا كان بالماينس معناتها أقل منهم. If it's in positive, then he's better than them. And what you mentioned later is about the pattern deviation is that this will actually filter for you any media opacity. It's like the software is giving you a curve, يعني upgrading your scores to eliminate any media opacity. So correct. Continue, please.
Then we can see the glaucoma hemifield test, which is outside the normal limits. And then we can assess the severity of the patient, which we can see here by being 8.46, which is a moderate glaucomatous damage. We can compare
Excellent.
the visual field of the patient to the examination to see about the, for example, we see it here in the temporal side, so we'll expect the defect to be in the nasal side on the optic disc.
Good.
Like,
So you are having
yeah.
a thinning significantly superiorly, and you have the densest scotoma inferiorly corresponding to the superior thinning. And you have as well here inferotemporal thinning. That's why you are having a corresponding superior scotoma as well. Thank you very much, Doctor. So I'd like to have another volunteer, please.
Can we have Dr. Abdullah Khan?
Assalamu alaikum.
So Dr. Abdullah, this patient underwent a glaucoma surgery. So describe what you see in front of you.
So this is the slit lamp photos of the right eye. We can see the lens looks with the normal, the conjunctiva, superior looks conjuncted, and also there is thinning, and it appears that there is like the conjunctiva. I'm not sure if it's covering the tube well or not.
Okay, so you see, Manish, do you see the arrow that I'm putting or pointing here?
Yes, the tube.
Yeah, so that's a tube. So what kind of surgery you are having here?
So here it's a tube surgery, either with valve. So either
Excellent. So what I want you to say here that it's a tube surgery. I don't exceed this because you don't know. Is it Burvelt? Is it Ahmed? Is it Orolab? Is it Maltino, Kropin, whatsoever? So that's only a tube surgery. So correct. Now, what are the indication of tube surgery? So whenever we make a decision to go for tube surgery, we should have certain indications. So can you mention for me just 2 indications to go for tube surgery?
Usually we use it in cases like uveitis cases or in cases of failed filtering surgeries. Right.
Okay, excellent. So what you mentioned now is failed filtering surgery like trabeculectomy, and that's 100% correct. You can go ahead with tube surgery for patients who are having uveitis as first option sometime in hot eye, or if you can go for tube surgery in patients who are having anterior segment dysgenesis, for example, as a first option. You can go as well for tube surgery in patients who are having as well high tendency for conjunctival scarring. So that's a better option for our glaucoma patients. Now, you have done a tube surgery for your patient. Then he came to the emergency room complaining of foreign body sensation. So describe what you see in front of you right now.
So here I can see what is striking. There is conjunctival slightly injection and also exposure of the tube.
Excellent. So the patient is having exposed tube. So if the patient now is coming to you to the emergency room with exposed tube, how would you approach your patient?
Yeah, sure. So first of all, we'll approach with the history. I will ask when was the surgery, when he started to notice this foreign body sensation. Does he notice that any tearing in the eye, any discharge, any pain, any decrease in vision? And also ask about systemic disease and also.
Excellent. So what doctor mentioned is that he will ask in the history about the surgery, when was it done. Some of you might think that this is not important, but actually it's of extreme importance for us, because if this is a recent surgery of 3 months duration, and the patient already developed this thinning and exposure, it will highlight us that actually, even if you revise it again, with the same patch graft, the patient might have recurrent exposure. So you'd like to change the type of graft that you have used before, or at least have it a double pericardium if it's pericardium before, or preferably change it to a stronger patch graft. You mentioned the history of trauma, or patient is having any itching or any other associated disease, or systemic disease, or if the patient is having swelling or discharge. And these are very important things for us to know if the patient is starting to develop any infection. So let's say that the patient is having a surgery for 1 year, and he came to you because of this foreign body sensation. There is no lid swelling, no discharge, no systemic disease at all, and no trauma. So how would you approach this patient now in clinical examination point of view?
So in clinical examination, of course, we start with examining. Already now we know about the list. I will start with the visual acuity, the IOP.
Excellent. So visual acuity is very important because you need to have a baseline. If the patient developed to infection, at least you documented a baseline and you can monitor the patient for progressive or progress infection later on. You mentioned the pressure, and that's very important because you are not sure if there is leaking from the tract surrounding the tube or not. Continue, please, doctor.
So now slit lab examination, including first we have to rule leak and also look for discharge. Look for signs of infection. Like we will see exactly if there is pus in the tube or is like pus around the tube and the exposed area.
Excellent.
AC, we will look for AC cells, look for any hypopyon, any KBs. After that, we'll look also for the fundus. We have to examine it as well for baseline. And also one thing regarding the plate, we have to look at it. Is it only the tube or also the plate is more?
Excellent. So you mentioned all the important things that we need to make sure about. And also you need to look at the vitreous cavity to document if the patient is having vitritis or not, or if the patient is having pigments in the vitreous so that it will not confuse you later on, and vitreous opacities as well, so that you will not be confused if the patient is developing vitritis and endophthalmitis later on. So you need to document these things very well upon your initial assessment. Plus that you need to examine the periphery of the retina, looking for the earliest sign of endophthalmitis, which is
sheathing, and also like vitreous cells in the periphery.
Exactly. So vitreous condensation vitritis and peripheral vasculitis are very important early signs of endophthalmitis. So if the patient does not have any sign of infection, what would you like to do for this patient right now?
So since there is no infection and it's already 1 year, first I will have to revise the operative note initially. What was used to cover the tube? Was there any, like they used anything to cover the tube? If the pressure is okay and the valve is functioning, actually we can just use patch, cover the tube, and then close the conjunctiva.
Good. But before doing this, you need to cover the patient with antibiotics. Sure. So because he might have just a recent onset exposure, and he might go into the track of infection. So make sure that you will cover the patient with antibiotics, broad spectrum antibiotics. Okay. Sure. So if the patient develop, let's say, is having +2 cells and +1 vitreous cells, what does this tell you?
So here we are afraid that there is the patient has an infection and it could be endophthalmitis, early endophthalmitis.
What would you do for the patient?
Since there is vitreous cells, I will do the injection. I will take vitreous tab, and also will start with the intravitreal injection.
Okay. Do always cells in the vitreous means that there is vitritis? So you have something called spillover inflammation, right, from the anterior chamber going to the posterior chamber. So you want to make sure that is it spillover inflammation or not. So most of the inflammation is condensed in the anterior chamber, and you have few cells in the posterior in the vitreous. Then it will be away from being endophthalmitis unless you examine the vitreous cavity very well and examine the periphery of the retina and have your baseline B scan. So baseline B scan is important because it can show you if there is RC layer thickening.
Correct.
So you want to establish a baseline B scan for your patient, and the take-home message here is that you must admit your patient. Why is that? Because he might progress rapidly to endophthalmitis, and you need to consult our retina colleagues for the option of giving, as you mentioned, intravitreal injection if the inflammation in the vitreous cavity is significant and mimicking the anterior chamber inflammation. So if you have dim red reflex, what would you do for the patient? You cannot see the retina.
Of course, do B
because
scan.
let's say because of dense cataract.
we must do a B scan to assess
Okay.
the phthalmitis. And
Good.
yes.
Okay, thank you very much, Doctor. So we have multiple types of glaucoma drainage devices. The most popular glaucoma drainage devices that we have and we are using nowadays are the Ahmed implant on your right side and the Bervelt shunt on your left side. Major difference between both groups is that the Ahmed implant is valved. The Bervelt is non-valved. However, some surgeons have high tendency to use the Bervelt, although it's non-valved and there is a risk of early hypotony because there is no valve. So the drainage of aqueous will continue and you will have collapsed anterior chamber. So we can overcome this issue by actually having ligating suture. So what makes Bervelt implant having or gaining popularity is actually that it's having a large surface area. So the encapsulation will be less. However, on the other hand, with Ahmed implant, since they moved from, since they moved to a silicone-made plate, it became more biocompatible and the encapsulation became much more less with the Ahmed implant. Remember that we mentioned before that Ahmed implant is valved and you have a Venturi mechanism that allows the aqueous to be drained through the Ahmed implant and will avoid hypotony if the pressure is less than arguably 8 millimeter of mercury. And you have here multiple types of glaucoma drainage devices. You have the Ahmed implant, as we mentioned, which is the most popular now or the type that we are using right now is the FP7, which is made of a silicone tube and a silicone plate. The polypropylene, we don't use it anymore nowadays. And the Bervelt is made of silicone tube and silicone plate. So that's why both of them are biocompatible. But you can see here the surface area of the Bervelt is larger than the FP7 Ahmed implant. And that's why the arguably the encapsulation might be less with Bervelt shunt, but this is to be proven by further studies. I'd like to have a volunteer here.
Can you have Dr. Ibrahim al-Mansour?
So Dr. Ibrahim, this patient sustained a blunt trauma 3 days ago, and he came to you, he's having +1 pigmented cells in the anterior chamber, and he's having SPKs and blurry vision. So, and the patient is all yours. What you will do for him?
Okay, I will start with taking a proper history.
Okay.
What kind of trauma he sustained?
It's a blunt trauma by stone.
By stone. Any medications given to the patient or any?
No, nothing at all. His vision used to be 20/20, and now it's 20/40.
Okay. Any other symptoms? I mean, pain, discharge?
Yeah, he's having some pain, but nothing else. Blurry vision and pain.
Okay.
Vision is 20/40 now. IOP is 12.
12. And any medical history away from the trauma?
Nothing at all.
Negative ocular history and family ocular history.
Yes.
Okay. I will proceed with the examination. You said the visual acuity is 20/40 and the IOP is 12.
Yes.
And the patient has SPKs.
Yes.
Okay, and then I will check. Before I will start with checking the conjunctiva, rolling out open globe if there is any subconjunctival hemorrhage. Yes, assessing the cornea. You said there is SPKs, and the AC. Yeah. You said 1+ pigmented cells.
Yes.
The iris is normal in place.
Yes.
Yeah, and the lens is clear.
Yes.
And I have to examine the fundus to make
Looking
sure.
for what?
Yes, if there is any vitreous hemorrhage, break, commissure, any commissure retina, or yes, or RD if there is a break, although it will be later.
Okay. So
yes.
what do you see here in this gonioscopy? Describe
Yes,
what you see.
I can see a wide ciliary band, and
Okay.
I think, and hyperpigmented angle.
Okay.
Yeah, and the angle is open, definitely.
Okay. So what do you see? What's the diagnosis? What do we call this?
Cleft. It could be.
No. You mentioned it just now.
Yeah, you mean the city?
What is this? This is angle recession, right?
Yet, but you said this is a 3 days later after trauma, right?
Yeah. So you have a wide ciliary body band. So this is angle recession glaucoma or what?
From what I know, usually the angle recession will not present in 3 days.
So you will have a traumatic angle recession, right? But you cannot say that it's glaucoma unless you comment on the optic nerve, if there is glaucomatous damage or not.
Yes.
That's number one, right? Number two, the pressure is 12.
And the IOP
but sometimes, but sometimes the pressure might be initially normal, then start to raise up later on. So what's the explanation of this condition?
You mean the high IOP later?
Yes. Why would the pressure increase later on?
Because there will be a fibrosis in the angle, and maybe initially because of the inflammation, the ciliary
exactly. So what happens is that sometimes you will have an inflammation of the ciliary body because of the trauma. You will have shutdown, and with time, because of the trauma, you will have trabeculosclerosis, trabecular dysfunction because of the trauma itself. So with progressive dysfunction of the trabecular meshwork, with time, with age, the patient might develop later on high intraocular pressure. That's why it's extremely important for us to observe the patient for how long after we diagnose him with angle recession, when he might develop a glaucoma.
After 1 month.
For how long do you need to observe him? 1 year, 2 years, 3 years with angle recession?
For life.
Exactly. So that's the message. You need to observe the patient for life, because at any time his trabecular meshwork might dysfunction or might reach the threshold that it cannot drain aqueous anymore properly, and there will be loss of balance between aqueous production and secretion and drainage. And at that point, the patient will start to develop high intraocular pressure, which will cause damage to the optic nerve, and then he will develop angle recession glaucoma. So by the way, what does happen in angle recession? There is a separation between which and which?
The circular and longitudinal ciliary muscles.
Excellent. So that's a UBM of a patient who is having an angle recession. You can see that there is a normal angle here superiorly. You can see that that's the ciliary body, that's the sclera, that's the Schwalbe's line, and that's the scleral spur here beneath it. And you can see that there is a widened area of ciliary body band. And you can see here the posterior chamber, the anterior chamber, the lens and the lens capsule and the cornea. So when you compare between both superior and inferior parts, you can see that there is extremely widening part of the ciliary body face compared to the superior part. Do you see my arrow on the slide?
Yeah, it's clear.
So look here at this whitish arrow and look at the corresponding area of the whitish arrow and look at the expanded area here. So look at the ciliary body band, which is appearing here, and compare it with the area superiorly here. So there is a wide band of ciliary body being exposed right now. And you can see that the scleral spur is still in place. So what you have is posterior displacement of iris scleral insertion and widening of ciliary body face with no disruption of the interface between the sclera and ciliary body. Because if there is disruption between the sclera and ciliary body, then we are having something else called?
Between the sclera and ciliary body?
Yeah, if there is detachment between the sclera and ciliary body.
The cleft, ciliary body cleft.
Exactly. So whenever you are assessing, thank you very much, Doctor. Whenever you are assessing an optic nerve head, you need to make sure about some variabilities that you might have, some abnormal features of the optic nerve head that you might have, and don't always be occupied by glaucomatous damage. Khalid, I need a volunteer, please, just for a quick comment on these optic nerve head slides.
Walid Sarhani.
Okay, so Dr. Walid, you have 3 optic nerve head photographies here. So what are the differences between the 3?
طيب, to start with the image at the top to the left.
Okay.
This looks like an optic pit. Since there's
excellent. So why do you call it pit? What's the striking sign that tells you that it's a pit actually?
Since there is excavation allocated at the temporal part of the disc.
Okay, and?
With adjacent peripapillary pigmentation.
Okay, or what we call autoscarring, right? And what about the slide on the right and the lower part? Or the photos on the right and the lower part?
So the photo to the top to the right, I can see a large disc with a relatively large cup, about 0.5 cupping. The neural reticulum is healthy. The disc margin is healthy, and the vessels look intact.
Good. The inferior part?
The inferior part is, I can see a cupping, mainly focal cupping with inferior notching.
Okay, so why would you say it's focal? Because when you compare to the superior and inferior poles, you are having more thinning inferiorly than the superior part.
Yes.
Okay, so Walid, this patient present to you, she's 12 or she's 10 years old, and she was referred to your glaucoma clinic because of uncontrolled pressure, and she's having -12 glasses. So what do you see here?
This is external photo that shows clear cornea. The image on retro illumination shows a subluxated lens, and to the bottom shows corneal edema with the shallow AC, relatively shallow AC.
Okay. Okay. So what do you think is this?
The lens looks small and spherical, so I would think about microspherophakia causing angle closure glaucoma.
Excellent. So how would you approach this patient? What would you do for her?
In this case, there is an attack of pupillary block or angle closure. So I would start with medical anti-glaucoma medications, trying to lower the IOP, and then I would proceed with the YAG-PI if possible, and then surgical removal of the lens.
Excellent. So is there any associated features that you might think that the patient is having as well?
In microspherophakia, it is usually associated with the Will-Marchesani syndrome, which is an autosomal recessive condition associated with small fingers, short stubby fingers, and short.
Excellent. Excellent. Thank you very much. I need one of the volunteers from the first year residency, R1.
Dr. Budur Salman.
Okay, Dr. Budur, this is a 6-year-old lady who came to you to the emergency room because of pain, redness, decreased vision for the last 1 week. So how would you approach this lady?
طيب دكتورة بدور, I don't think she's with us. دكتورة ابتهاج.
الو السلام عليكم.
Alaikum assalam. So
Okay,
yes, go ahead.
I will start with the description. I'm presented with a slit lamp photo of an eye with slit beam illumination showing a central opacity in the cornea.
Okay. So the patient is having corneal edema. What about the depth of the anterior chamber? Is it deep or shallow?
Yes, there is also a shallow AC and diffuse conjunctival injection, 360 degrees.
Okay, excellent. So what about the lens? It's white, right?
Yes.
So it seems like a mature cataract. So if you cannot see through the lens to the posterior chamber, so you would call it mature cataract, right?
Yes.
So how would you approach the patient right now? What you will do?
Okay, does the patient have a high IOP?
Yes, the pressure is 50.
Okay, and there is a shallow AC. So my first differential diagnosis will be phacomorphic glaucoma with a mature cataract.
Okay. So what you will do for the patient?
Okay, so I will start with anti-glaucoma medication. Systemic and topical.
What kind of systemic, what kind of topical?
I'll start him with topical timolol and durzelamide and systemic acetazolamide.
Okay. So after, let's say, half an hour, the patient is coded.
Coded?
Yes.
What does coded mean?
Coded, code blue.
Okay. I should ask first about, I should first ask in the history about contraindication for acetazolamide.
Excellent.
And,
so whenever we ask you to approach the patient, you need to make sure about the systemic disease, associated systemic disease. And before giving the patient the medication, especially systemic medication, just ask about contraindication.
Yes.
And you need also, you missed one important thing, which is the vision. Does the patient see or not? Is it blind eye or not? So you need to make sure, is it a seeing eye or not? So that's very important. So now you mentioned that you will lower the intraocular pressure after making sure that the patient does not have any contraindication for the medication. You will give him acetazolamide, topical anti-glaucoma medication, and the pressure decreased to 20. So what you will do for the patient after that?
Okay, so then after the edema has resolved, I will address the cause for phacomorphic glaucoma, which is cataract extraction. I can also do laser BI before cataract extraction.
Excellent. So you must do YAG PI after lowering the pressure and having a clearer cornea. And there is something else that you must do. So you need to check for the other eye, right?
Yes.
To make sure if the patient is having a positional angle closure or not. Another important thing is before you take the patient to cataract surgery, you'd like to know if the patient is having retinal detachment or not, if the patient is having tumors or not. So
yes, so we should do P-scan ultrasound first.
Yes, excellent. So now that's the picture of the patient after you did for him after you lowered the intraocular pressure, you did PI. And now the eye is quiet after 1 week and the patient is happy. What will you do for the patient? You did B-scan and the B-scan is normal. What kind of surgery you will do for the patient?
We will go for cataract extraction.
Okay, what kind? Phaco or what? ECCE?
I think we can do phaco.
Okay, phaco is amenable and ECCE is amenable as well. Let's go with your option. You tried to do ECCE and you referred it to one of your colleagues and he tried to do ECCE and he ended up with this picture. So what's this?
Okay, I'm presented with a slit lamp photo of the anterior segment of the eye with diffuse illumination. There is peripheral corneal opacity, mostly peripheral, but also involving the central.
And there is a lens anterior to the iris, right?
Yes.
There is an IOL anterior to the iris. So this lady came to you while you were on call 3 weeks ago, and she came to you again while you are on call having the same problem, pain and headache and pressure of 60. What's the problem here?
Okay, there is a dislocated IOL.
It's intended to be anterior to the iris. So what kind of IOL is this one?
Okay, it's an AC IOL.
Excellent. So the patient came with a high intraocular pressure after having an AC IOL. What could be the problem?
It could be the problem, pupillary block glaucoma.
Excellent. So what did the surgeon miss?
Yeah, he missed placing a surgical BI during the OR.
Excellent, excellent. Thank you very much, Doctora. So that's the cyclodialysis cleft that we talked about before. If there is a track or communication between the supraciliary space and the anterior chamber, it will be, of course, because of detachment of ciliary body from its normal location, and you will have subsequently something called cyclodialysis cleft. So I need a volunteer, please. Preferably fourth-year resident. Any volunteer?
Does it have to be fourth year?
Third year ما هي مشكلة.
طيب.
Or second year, whatever. يعني ما هي مشكلة أي حد.
دكتور راكان الجرينيز.
Okay.
السلام عليكم.
Dr. Rakan, this is a 50 years old gentleman who is following up with me in my clinic. And I always assure him that everything is fine, don't worry. And he disappeared for 2 years. And he came with poor compliance on medication, having this picture on your right hand and having this visual field. His pressure is 20 and he's having poor compliance. His last visual field was almost normal, only nasal step. And he came now with this visual field. Pressure 20 on Cosopt, Alphagan, and Zalatan. So what would you do for this patient? Describe the finding in the right side and the left side, briefly.
Okay, the right upper photo is a gonioscopic picture showing the angle with multiple peripheral anterior synechiae.
Okay, so these peripheral anterior synechiae, would you call them high or low?
I think high.
High because they exceed the trabecular meshwork, right? So these are high peripheral anterior synechiae. Okay, and what about the disc?
It shows cupping with notching at the inferior side, I think.
Excellent. And the visual field?
Dense superior arcuate scotoma.
Okay. So what would you advise this patient to do?
Since he presented with this picture, this is mostly a chronic angle closure glaucoma.
I'd like to use primary angle closure glaucoma. It's better than chronic.
Okay. I would advise the patient to, if he is, using his medication regularly.
He's claiming, but he's not using them. So, patient who's not compliant on medication, having this progression within 2 years, what would you do for him?
That means this is one of the indications to proceed for surgery.
Okay, what type of surgery you'll do for this patient?
Maybe filtering surgery.
Okay, what type?
Like trabeculectomy.
Why not deep sclerectomy?
Deep sclerectomy necessitates the presence of open angle.
Excellent. So you have in front of you now a synechia. So it might exist at the trabecular descent window, and it will block the filtration. So it doesn't make sense to go for deep sclerectomy in angle closure glaucoma. So you did for the patient combined procedure because of coexisting cataract, and he came to you first post-op day with this picture. So, and the pressure is 17. What's happening here?
In the right photo, I see a slit lamp photo of the eye, which shows diffusely shallow angle or flat shallow anterior chamber. Okay. Because it spares with no lenticular corneal touch.
Okay. How would you grade it? Grade 1, 2, or 3?
Grade 2.
Okay, so grade 2, maybe grade 3 because we don't have a clear slit on the IOL. But grade 2 is fair enough because there is complete contact between the iris and the cornea. And now you can see the posterior pole, right?
Yes. It's hazy
Okay.
because of yeah.
Okay. You took the patient to the OR because of progressive thinning of the anterior chamber, and you reformed the anterior chamber. And after that, the patient came again with the same picture. And you cannot see the posterior pole very well. What would you do for the patient?
I can do a B scan.
Okay, so keep in mind the pressure is still 17. So do B scan looking for what?
Reasons for the flat anterior chamber, including suprachoroidal hemorrhage.
Okay, so here, both me and you are lost. Why is that? Because we did not go systematic, right? So one of the things that we need to do right now is to go back and be systematic. Whenever you are going systematic, you will never be lost. So one of the things that you need to start with is, of course, when did he do the surgery? And when did you see him? Let's say now you see him, or sorry, you saw him first day post-op. Now what you need to do is to check the visual acuity. So the patient's pre-op visual acuity was 20/40, for example. Now it's 20/200. You'd like to check the blib configuration. Is it a large filtering blib, or is it a flat blib? Is it leaking blib, or it's not leaking? Then you will assess the anterior chamber depth. After that, you will examine the posterior pole. You will look for any choroidals, and you will look for a baseline B scan with gentle pressure if you are not sure about the existence of peripheral choroidals, and you might need to use something else, which is, along with B scan?
UBM.
Excellent. Looking for what?
Anterior rotation of the ciliary body.
You want to discriminate between what you mentioned, anterior rotation or annular ciliocoroidal effusion. Okay?
Yes. And also, I think the presence of PI, whether it's present.
Now, you did the B scan, and it did not show you anything. But you did the UBM, and it showed you a ciliocoroidal effusion. You can see that the ciliary body is edematous compared to the ciliary body here. And you can see that there is separation of the ciliary body from the sclera. And you can see that there is translucent supraciliary fluid. Remember that, we just go to the previous slide. Remember that in cyclodialysis cleft, you will have complete separation of the ciliary body from its normal location, right? You will have a complete communication between the anterior chamber and the supraciliary space. That's in cyclodialysis cleft. While in ciliocoroidal effusion, the ciliary body will still be attached, but it's edematous and separated from the sclera posteriorly with the presence of translucent supraciliary fluid. So if this is the picture that you are having on UBM, what you will do for the patient? How do you manage the patient? Let's say that the patient is having grade 2 shallow anterior chamber. There is no contact between the IOL and the cornea, and there is no leak from the blib. How would you manage this patient?
Doctor, you mentioned that the IOB is high.
17.
Okay. I think I will start with cycloplegia.
What kind?
I can use atropine and cyclopentolate together.
Okay, so you will use atropine. That's the most powerful cycloplegic agent available in our hospitals and institutes. And why would you use atropine? What will it do?
It works both to cycloplegia the ciliary muscle, and it helps as an anti-inflammatory as well.
Okay, so its anti-inflammatory effect will help to reduce the edema of the ciliary body, as you mentioned. It will deepen the anterior chamber and prevent further shallowing. But there is something else missing in ciliocoroidal effusion. Other than atropine, what do you need to do? There is one medication that you need to increase.
Maybe I will use topical steroid as well.
Yes, so you need to increase the frequency of topical steroids. Why? You need strong anti-inflammatory agent to help you controlling the edematous ciliary body, to get rid of the inflamed ciliary body right now, right? So once you resolve the ciliary body edema and you use atropine as well to deepen the anterior chamber and to relax the ciliary body, so at that time you might have decreased ciliary body edema and you will get rid of the ciliocoroidal effusion. Now, on the other hand, if you have done UBM and it showed you an extremely shallow anterior chamber with closed angle and forward rotation of the ciliary body with minimal or none suprachoroidal space fluid, but flattened ciliary body opposite to what you have in ciliocoroidal effusion. So we are having a picture of aqueous misdirection. Well, how would you manage this patient in such condition? What you will do for him?
The same. I will start by powerful cycloplegia.
Excellent.
Maybe I can use all of the medications like atropine, cyclopentolate, and phenylephrine.
Okay. So the patient's pressure increased from 17 to 25 after 2 days. What you will do?
I can do a PI for the. I will check if the patient has.
So we agreed that there is already a PI. What you will do for the patient now?
I can use YAG.
Remember his pseudophakic.
Yeah, which allows me to use the YAG laser to create a window.
Okay, so you will use YAG laser to do posterior capsulotomy and disrupt the vitreous face, right? The anterior vitreous face. Why you are doing this? What is your gain?
To allow the fluid to be diffused from the posterior to anterior.
Because the aqueous is hydrating the vitreous, which is helping more in a vicious circle to push the IOL iris diaphragm more anteriorly, and forward rotation of the ciliary body, as you can see here, will be more and more. You want to break this circle, right?
Yes.
Because once you have everything moving forward, the angle is being closed more and more. So you're having vicious circle with aqueous misdirection. So if your attempt fail, then what you will do?
What I know, doctor, is to have another trial in another maybe place if I have. The other option
is the pressure is now 40. What you will do?
Then I will proceed by doing pars plana vitrectomy.
Okay, so it's not only pars plana vitrectomy, because if you do pars plana vitrectomy, some people might go for core vitrectomy, which is not right. You need to have good, complete pars plana vitrectomy and zonulo-irido-hyaloidotomy. Why is that? Because you must have a single chamber between the anterior and posterior chamber and the vitreous cavity so that the aqueous can freely pass from the posterior chamber to the anterior chamber and relieve the pressure being opposed on the ciliary body and the iris lens diaphragm.
Okay.
Thank you very much, Doctor. So that's our previous patient. He underwent combined trabeculectomy with cataract surgery, and he came after 2 weeks with this picture. Can I have a volunteer just to tell me what is this spot diagnosis?
Dr. Rakan Laisi.
Dr. Rakan, spot diagnosis.
Yeah, this is the white on red appearance, blebitis, rule out blib-related endophthalmitis.
Excellent. So approach this patient. What you will do for him? He was operated just 1 week ago, let's say, 1 week. And his vision dropped from being 20/40 to hand motion.
Okay, so I'll start with the history first. I will ask about when he had the surgery.
1 week ago.
1 week. I will ask about the redness, when he noticed the redness and the decrease in vision.
That was 2 days ago.
2 days. Any discharges?
Yes.
Is he using any steroids? Any history of trauma?
He's still on tapering steroids, but he's using to rub his eye.
Rubbing his eye. Is he on antibiotic?
Yes, he's still on Aflox.
Okay. No history of trauma, right?
No, he just only rubbed his eye.
Okay, good. So we'll go to examination. I will examine the visual acuity, IOP.
Hand motion, IOP 5.
5, okay. Then I will examine the eye. I will check if there is pus leakage from the bleb.
So there is pus in the bleb, there is no leakage, and there is hypopion with fibrin and no red reflex.
No red reflex. So I will also need to, I will need to also dilate and see the fundus, looking for peripheral vasculitis. Or
so there is no view? No view.
I will do B scan.
Excellent.
Mm-hmm.
What do you think the kind of organism here?
In early, usually gram-positive staph epidermis. In late, usually strep pneumonia or H. influenza.
Which is more virulent?
Strep pneumonia is the most aggressive because it causes necrosis.
Excellent. So strep is really no aggressive organism that we need to be very careful about. Now, why sometimes we don't have leak from the bleb? How did the organism go inside if there is no leak?
Usually there was a leak, but because of the pus and discharge, this sealed off the leakage site.
Excellent.
So in the examination,
you are having a fibrin which is sealing the leak actually.
Yes, exactly.
Yeah. So what would you do for the patient rapidly in 4 points or 5 points?
So I want to grade is it blebitis or with AC reaction or endophthalmitis.
So you have RC layer thickening now, and you have vitreous condensation and vitritis.
So this is bleb-related endophthalmitis. I need to admit the patient.
Okay.
Take conjugate swab, tab and inject, start fortified antibiotic, and plan for BBV.
Okay, excellent. Thank you very much, Doctor.
Thank you.
So that's the same patient, but with another scenario. He came on the first day post-op with this picture. So just one volunteer for 2 to 3 points regarding the management, what you will do for this patient. أي متبرع؟
دكتورة ديما.
السلام عليكم.
عليكم السلام. So he underwent trabeculectomy yesterday, combined with phaco, or sorry, trabeculectomy alone, and he came with this picture.
Okay, so in history, what is the main complaint of the patient?
Just he underwent the surgery. You came to see him in the post-op round. You just removed the patch, and that's the picture in front of you. What you will do?
Okay, so I'll start by taking the A of the patient, then the IUP.
So pressure is 20.
Okay.
What you will do for him now?
On exam, I can see a photo of the anterior photo of slit lamp photo.
Okay, so that's a subconjunctival hemorrhage superiorly coming at the bleb area, right? And you can see that there is hyphema and blood clot in the anterior chamber. Posterior chamber is fine. What you will do for the patient now? It's a recent trabeculectomy done yesterday.
Okay, so I'll start the patient. First of all, how is the bleb? Is the bleb okay?
You see just subconjunctival hemorrhage all over.
Okay, and was there anything eventful during the surgery?
Surgery went fine, but you are surprised to see him with this picture. He used to be on anticoagulants, so you are not sure if he stopped them or not.
Okay, so
it's a very simple thing. Just go to the point.
Okay, so I would start the patient on high frequency topical steroids and cycloplegia.
Excellent. Why is that? Why do you need to start him on high frequency steroids?
To decrease the inflammation.
Inflammation, and you don't want any imminent fibrosis at your bleb, right?
Yes, yes, to save my bleb.
There is one medication that you'd like to assure the patient to use it.
Cycloplegia as well.
Cycloplegia, excellent. Thank you very much, Doctor. طيب, I think we are short of time, so one volunteer. What kind of surgery that was done for this patient?
دكتور الزبير.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
What kind of surgery? I can see superior. There's a blip.
There is something here on your right hand.
Yeah, I'm not sure. Is it a tube?
So that's a shunt, small shunt, mini shunt.
Mini shunt.
Yeah, so that's express shunt, express mini shunt. Huh?
Yes.
So the patient came to you after 1 week with this picture.
Yes. This is the slit lamp photo of the eye with the slit beam showing a clear cornea. The AC is shallow with, I can see iris Bombay.
What's the difference between express shunt and trabeculectomy in the surgery? What's the difference between them? That's why I brought this slide.
I'm not sure.
You don't need to do peripheral iridectomy in express shunt while you do it in trabeculectomy.
Okay.
Okay, so now, again, Dr. Zubair, so that patient underwent a glaucoma surgery. And what kind of surgery? If you can focus here, what do you think the type of surgery?
This looks like a tube surgery.
What kind of patch graft that was used for this patient?
Scleral graft.
So here it's actually a scleral flap. So the surgeon here made a scleral flap and he inserted the tube under the scleral flap, like what you do in trabeculectomy. So remember, in glaucoma drainage devices, you can have a pericardium patch graft, you can have cornea preserved in glycerin patch graft, you can have a donor scleral patch graft, or you can actually create a scleral flap if you don't have patch grafts. So not having patch graft is not excused not to operate the patient. You can create a scleral flap and insert the tube under it, like what you do in trabeculectomy, but make sure that the sclera is of good thickness so that there will be no erosion or complications.
Okay.
So one last thing for you. What kind of glaucoma surgery is this?
This looks like endoscopic cyclophotocoagulation.
Excellent. So in endoscopic cyclophotocoagulation, what kind of laser that we use?
I think we use the diode laser.
Excellent. Why do you use diode? Because the absorption by melanin in the ciliary body epithelium is more compared with YAG and argon. Our retina colleagues used to use the argon or YAG laser before. Energy required for treatment is less in diode, and therefore we are having less inflammation. Stromal coagulative necrosis with diode is less, and therefore the risk of phthisis is less. Pigment dispersion or bubble formation is not happening compared with argon, and tendency to undertreat is not existing in diode laser compared with argon laser. I think we will stop at this moment. It's now almost 9:10. Thank you very much. I need to jump now for another meeting. Thank you very much, Dr. Khalid.
الله يعطيك العافية دكتور، شكرا.
Thank you.